So welcome to educational webcast, which is produced by eCancer. And my name is Meral Beksac from Ankara University Department of Hematology. And I'm being joined by myeloma plasma cell disorder expert, Professor Roman Hájek from the University of Ostrava. And hello, welcome. And today we are going to be talking about a study, Integrate, which has been presented during the last ASH meeting in Atlanta as a poster. And this study is quite unique in terms of the real-world data being collected from 45 centers from 8 countries. And among these 8 countries, we can name Argentina, China, Republic of Korea, Russia, Saudi Arabia, South Africa, Taiwan, and Turkey. So the intention of this study was to collect data of both newly diagnosed and also relapsed myeloma patients in the real world. And the inclusion criteria included patients who were diagnosed beginning of 2010 and end of 2011. So during a 2-year period, patients who were eligible for these criteria were recorded, and as a total, a little more than 2,000 patients were included in the study. And in the distribution of patients, there are 1,500 patients for newly diagnosed and 600 patients in the relapse setting. If we summarize the features of these patients, it's roughly similar to the myeloma distribution for the newly diagnosed and also relapse setting in terms of gender and age distribution. But ISS3 is the most dominant category of myeloma patients in both the newly diagnosed and relapsed patients. And based on the drugs which are approved in this wide range of countries during the study period, there was a wide distribution of drugs being used. And the aim of the study was, the primary endpoint was time to next treatment. And secondary endpoints are response and overall survival, and also other survival-related parameters. When the distribution of drugs for the newly diagnosed myeloma is evaluated, the most dominant drug type is more than 60% bortezomib, which is followed in the second frequency thalidomide. And in the second line of therapy, we have a decrease in bortezomib and an emergence of lenalidomide. And for the third line, the lenalidomide treatment becomes the most dominant drug of choice. For the relapsed myeloma, the distribution is similar, but we do not see many patients who received lenalidomide as much as it was in the newly diagnosed, was possibly due to the approval status of these drugs in the given countries. And regarding the impact of or the utilization of stem cell transplant, it is very different than what is seen in the developed countries. For newly diagnosed myeloma, among those who are eligible for transplant, only about 1/3 were receiving stem cell transplant at frontline. But when it comes for the relapsed patients, the frequency of stem cell transplant utilization increasing and doubling more than 60%. And the comparison of stem cell transplant done versus non-done, there's a great difference in terms of both the median overall survival and also the relapse-free rates. And the difference, the impact of stem cell transplant is bigger on earlier lines And this also is valid for first and second line in the relapse setting. But after the third line, the impact of stem cell transplant disappears. So emphasizing the importance of stem cell transplant, the earlier the better. And in general, the conclusions from this study is that the time to next treatment, progression-free survival, and overall survival rates are similar. And we may also emphasize that the time to next treatment in the newly diagnosed for first line is around 36 months, which is a quite good value. And the transplant effect is also visible in the real world, but the frequency of stem cell transplant is not as much as it is seen elsewhere. And I think this study provides a platform for comparison for newer drugs and newer treatment modalities. And of course, take into account that the study was conducted on patients who are diagnosed between 2010 and until the beginning of 2012. So Roman, this is what the general outlook of the study is, and we may discuss with the real-world experience that you have.
Meral, it's thanks for this overview. I think it's excellent job from all of you. I think the huge, robust cohort and quite solid data from, I think, 8 countries, if I calculate correctly.
Yeah, 45 centers, 8 countries.
Yes, so nicely done. And I think the real world evidence coming more and more important because we definitely need always validation from real world and real life if some regimens really working as suggested by clinical trials. So this is this nice observational study, and once again, congratulations. I have, in fact, 2-3 questions. One, it was nicely shown that autologous transplantation still matter in newly diagnosed setting, as the data, this 1/3 of patients underwent transplantation. Did you see any difference between the countries, like significant difference? In some countries, limited number, and some countries, higher numbers?
So far, I do not have that data, but we are at the publication step now. And during this stage, we may be able to recruit that data. But I think it's more related to centers rather than countries, because in each country, there might be very diligent centers who perform transplant. So this could be one of the reasons.
The second question, because this is observational trial and the covered period was 10 years ago. So that's the reason why the basically evaluated regimens are bortezomib-based, lenalidomide-based, or thalidomide-based, or even conventional drugs. Yeah. So and I think you already mentioned it. It would be a really nice starting point to compare the new triplets in the future, how they change scenario.
Yeah, you're right. I mean, it's the next step is to have more current data and use this integrate study result as the comparator arm. And this can be a model for demonstration of the improvement with the inclusion of newer drugs, which are more potent, as we know from the clinical trials, if they will have the same impact in real world experience.
Yeah, and just one comment that would be, I think the interesting point, because, in different countries, there are different approval and reimbursement strategy and policy. So that would be really nice to have chance to analyze if different reimbursement policy change the story in myeloma prognosis. That would be nice to see.
Yeah, sure. We know that some countries are behind approvals with newer drugs, and we see in this study the emergence of lenalidomide in the later lines, and in many countries still lenalidomide is not approved for frontline, and that would have an even bigger impact on frequency of relapse.
You ask about our experience with real-world evidence. We had actually update of our analysis on this ASH, focusing of XRD versus RD regimen. We just confirmed that the difference between progression-free survival between RD regimen and XRD in real world is almost doubled. You know, the progression-free survival adding ixazomib to RD doubled progression-free survival, and also prolonged statistically significantly overall survival. I have to say we didn't see such representative result, which are really close to original Tourmaline MM1 clinical randomized trial. We didn't see such result with different combination. From some reasons, the results were not so good as an original clinical trial, which is understandable. And usually the progression-free survival is like 70% of original suggested by randomized clinical trials in the real world. But we were surprised it wasn't the case of XRD regimen in our hand. So that was, I think, very impressive.
So I support your findings, and I think it's valuable in terms of during the most recent ASH meeting, the maintenance drugs combining IXA with lenalidomide, having a similar outcome with the comparator arm due to the toxicity, which is claimed to be an important factor. I think in real life, things are much different, and we are more flexible, and we reduce and stop treatments. But within a clinical trial, we are less liberal, we are more restricted, and that prevents maybe stopping or reducing and going back to the original dose and things like that, which would have an impact on efficacy. And nowadays, I think we are learning that doublets are certainly better than a single drug regimen. And in the COVID era, having 2 oral regimens is one and the easiest treatment modality. And for this purpose, it could be an option. But today, what the INTEGRATE study will give us as a reference value will be used for future, again, from the same region, because we know that regional differences make a real impact on outcome. Thank you so much, Roman. I think we have gone over our assigned time, and I hope we have been able to give the audience some impression about the INTEGRATE study and also the value of having real-world experience. Thank you so much for your contributions.
Well, my pleasure. Thank you too, Meral. Excellent.